Morning, everybody. Thanks for joining us. We've got a great topic this morning. I know you will all gain a lot of insight from this. Johnna Devoto, I've known her for almost 20 years now. She's an awesome woman, a dog lover like me, so you know she's a good person. You've probably read her bio online, so I'm not going to repeat the educational experience that she has. But just know that she has such a caring heart, just like I do, and a passion to help our patients cope with Parkinson's as well as their care partners. So thanks a lot, Johnna, for being on with us.
Oh, you're welcome. It's my pleasure as always. This is a topic that is part of my life's work. It's the thing that I find a lot of joy in working with all the folks that I see at UC. And what I'd like to do today is just have a conversation about the cognitive change that's very typical in Parkinson's, but direct it toward what's a way that care partners can kind of solve problems and plan with that information in mind, right? So that's sort of the strategy that we want to look at today. And now, let me see here. There we go, advancing slides. I had someone last week, so in my role as a clinical neuropsychologist at UC, I do a couple things, but my main role is in providing neuropsychological evaluations for folks with movement disorders. That's my area of expertise and my specialty. And I also do some psychotherapy with folks who have movement disorders and issues with mood or behavior. And in that role, I had a family person say last week, what my family says is I need to do a better job at coping with this. And by this person meant Parkinson's. And there was some uncertainty really of what was meant by that. She was not really clear what her family was referring to. And so I think it's helpful to kind of just break it down and define terms a little bit. I mean, all that coping really means, it's not some sort of generic thing where you wish that something wasn't happening that you don't have control of, or you wait for some, miracle thing to come and remove a disease that's been diagnosed. Really, in a very practical, nuts and bolts, pragmatic sense, coping just refers to a strategy. What's the thing that you do in that moment to manage a stressor or a problem? And there's lots of strategies, there's lots of coping styles. But when you look at the literature, coping styles that tend to be most adaptive and most effective and help improve quality of life and reduce distress are usually those that are rational, right? Based in thinking and problem solving. So a general statement from family to say, I'll do a better job at coping, what really became clear is that we needed to understand really what was the issue or the particular problem that a solution was needed for. And so what I think will be helpful is if we just talk briefly about the ways that Parkinson's can present, knowing full well that when it's a disease that changes over time, the strategy, that thing that you do, right, to manage a stress, there's going to be a need for reevaluation and readjustment over time. But just in general terms, I mean, and this is a slide that I've used previously, but I think it's helpful to hone in on what's the issue that's being raised, because we know the features of Parkinson's include those visible motor features that most folks associate with the disease. So these are things like tremor and slowness in movement, bradykinesia, rigidity and stiffness, difficulties with balance. And that's visually, it's what is most often associated. But for quite some time, we've been very aware that there are cognitive changes and mood symptoms that are integral, that are part of the disease process as well. Maureen and I have been doing this long enough. I'm telling on Maureen as well, that, you know, very early in my training, we used to talk that cognitive changes happen much later in the process. And we know that's not really the case now through our participation in multiple research projects and the research efforts globally. Cognitive change is pretty common earlier than later. And those mood symptoms that are present that relate to changes in the front part of the brain, it's a very common finding as well. So rather than thinking about coping as this sort of vague general thing, it's helpful to hone in on what really is the issue, what really is the thing, the problem that we need to come up with a strategy to address. And a lot of times, what you'll see, this sort of blue star here in the middle of this screen, what that refers to is that, you know, these cognitive changes, mood symptoms, and motor features, they don't happen in isolation. They interact and they work together to create sometimes some issues with functioning. One really good example of that is bradykinesia, the slowed movement that's such a common motor symptom in Parkinson's. I always say in clinic, it's bradykinesia has a close cousin. If that close cousin is bradyphrenia, which is slowed thinking. So these things work together to create some changes in memory, cognition, and overall functional status. Everyone's sort of familiar with that notion of the midbrain changes that are responsible for the development of Parkinson's and the emergence of symptoms. But as a neuropsychologist, what I see functionally is how those underlying brain changes affect the frontal lobe. And it's this front part of the brain that's so important in regulating mood and memory and thinking and behavior and insight. We'll talk about those here in a second. I also teach an undergraduate course at the University of Cincinnati, and it's been fun, but these are young underclassmen, mostly freshmen, sophomores, and just a few upperclassmen. But invariably, they always say, oh, well, what's the part of the brain that does this? Or what does this little part of the brain do? Almost like complex things are controlled by one small little part of the brain. And we know it's much more complex than that. So complicated cognitive abilities like remembering what medicines you take and when you're supposed to take them and where the medicine planner is, right? And the thing that you're supposed to do in an hour, remembering then to do it, not now, right? All of these really complicated day-to-day life events, life processes, are heavily dependent on the front part of the brain. And this is what's really, really vulnerable in Parkinson's. So you see sort of that red outline. I don't know if you can see that well on the screen, but that's in this sort of cartoonish picture of the brain. This red outline sort of highlights this area of the frontal lobe. Collectively, we would call these abilities that we'll describe here on the right side of your screen here. These would be classified as executive functions. And if you think about what an executive does, right? An executive organizes, plans, makes an adjustment midstream, initiates, considers multiple options. And so to me, that's an easy way for me to remember that the front part of the brain is responsible for executive functioning. So what does that mean? Well, the front part of the brain helps us maintain mental control, reason and plan and organize. The front part of the brain is also what helps you think about, hey, is this the best time to do this thing that I want to do, and control impulse. There are a lot of folks that just in the moment realize they want to get up, but kind of in that second, the cane that they rely on is resting against a chair that's out of reach, right? Or the walker is left in the other room and they kind of impulsively get up and then realize, oh goodness, right? So the front part of the brain is what helps you control impulse. It's also how you initiate, which, really what initiate means is starting to do the thing that you want to do. So a lot of times we'll hear care partners and family members say, here was the plan for the day. I left to go to the grocery and I came back and none of those things happened, right? Well, that's initiation. It's sort of that internal cattle prod that says, get up and do the thing that you want to do that's important to you. Frontal function, executive function. Sustaining attention, keeping track of multiple things at a time, multitasking, having good judgment, right? So sometimes folks will say, if this became unsafe for me, I wouldn't do it anymore. Well, the front part of the brain is what gives you really good information about whether you're safe or something's a good idea or not. And so sometimes we see risk-taking as a part of an executive change. Interestingly, the front part of the brain is not just about cognition or thinking, it's also a lot about emotions and mood regulation. Why is the experience of anxiety and depression so common in folks with Parkinson's, even if they've never had that at any other time in their life? And that's because of how important dopamine is in the functioning of the frontal lobe, and dopamine is important in regulation of mood. The biggie that we see is influence of the frontal lobe in Parkinson's on memory encoding and memory retrieval. So these memory processes, again, this is part of executive frontal functioning. So remembering back to that slide where we had motor and cognitive and mood in those different circles, when you add slowness of thinking, right, plus these executive changes, what can happen and how can that look? What can that look like on a day-to-day basis? Well, the big thing is distractibility, right? Being vulnerable, being much more easily distracted, trouble multitasking or doing something without losing track in the middle of it, right? It's that process is, oh, I'm going to get the computer ready or the iPad ready to sign on to the meeting. And then you realize, oh, I wanted to get a drink. I wanted to turn this off. Right? So that process of going through and completing a task without getting off track. And that's very, very common. As I had already said, the ability to quickly activate and start to do the thing that you want to do. And for some folks, they really need a care partner to be the person that helps set that in motion, right? So if you, as a care partner of someone with Parkinson's, know that they love or want to do this thing, but it's not going to happen unless you're there to get them started, then that's a really, really valuable strategy, right? So if it wouldn't happen without your intervention, then when you understand that really there's a cognitive reason why taking a walk in the afternoon, sitting out on the back patio to, enjoy listening to the birds, walking the dog, going to the gym, whatever it is, right? If you understand there's a cognitive reason to initiate, then it's much, much easier to develop a strategy where you guys plan and initiate those things together. The other thing, as I mentioned, is when executive dysfunction is there and there's slowness of thinking, when cognitive abilities are more effortful and the thing that used to happen automatically requires energy and requires effort, and you're aware of that in the moment, the sort of natural overflow or outflow of that is for many people to start to experience anxiety. That sort of uncertainty in the moment. Is this going to work? Where am I at with this, right? Spikes of anxiety in the midst of being overtaxed or too much going on in the moment. The same is true for depression, where it can be hard to kind of see that change and struggle with doing the thing that was quite easy 5 years ago, right? Symptoms of frustration and irritability, all in the moment, very, very common. And so if we know that there's a cognitive brain reason why those things develop, it's easier to develop a strategy and then work with your loved one in the moment. Let's talk a little bit more in more detail about what kind of memory change is typical in Parkinson's disease. I think about, you could get a bunch of different neuropsychologists in the room and have them tease apart all the different types of memory. And that could be a really interesting discussion. But in very practical terms, I think about memory in three ways. And that's the way we'll talk about it here. And the first thing I think about is getting it in, right? Encoding is the word that we would use. So entering new information into memory, encoding it. The classic sort of Parkinson's finding is that there's slowness in encoding. It's a slower process in learning new information. It doesn't mean new information can't be learned, right? But it's a slower process in learning. And the most difficulty is in the first time that you hear it. So first trial learning. So if you hear something only once, the likelihood that you've learned it and will remember it and access it is much lower than if you hear something more than once. And we'll talk about some strategies in a second. So that first sort of classic Parkinson's memory sign is poor encoding or slow encoding. The second is slowed retrieval. So even if you know something, and this is where sometimes frustration and anxiety kicks in, is where you can absolutely know that you know something, but right then in the moment, on the spot, blank, just not able to pull whatever that detail or that word is, or pull that out of your memory when you need to in the moment. And that's a function largely of slowed retrieval or slowed recall of the thing that you know. Those are the two main things. Interestingly, and this is one of the major ways that memory change in Parkinson's disease differs from that in conditions like Alzheimer's disease. In Parkinson's, there's that slowness in recall, and sometimes the recall is not there, but folks do much better at recognition, right? So when you know, when you see it or hear it, you know if that was the information or not, right? So hints and cues. A lot of times care partners will say, oh, are you talking about this or that? Or were you talking about Jim or Sally? I'm just making that silly example. And even if the person had trouble recalling that in the moment, as soon as they hear that, boom, they recognize that as being the accurate information. Why? Because it was actually stored and consolidated in long-term memory. So that, it's not hard to automatically jump to that knowing that, hey, we're going to use hints and cues. We're going to use that better recognition feature as one of the strategies when memory is a difficulty that affects day-to-day life. So slowness in encoding, with first trial learning being the most difficult. Slowness in retrieving what you know from memory, but improved performance and being better at recognizing something when you see it or hear it. That's that classic pattern of memory change in Parkinson's disease. We're not going to talk extensively today about anxiety and depression. I mean, that very, very easily it's its own separate discussion. But I do think in the person with Parkinson's and in the care partner, I really think it warrants a comment that memory and thinking functions can be impacted by a lot of factors other than just the brain changes that are happening. And so a lot of these other, so you see memory and thinking there in the center of the slide, and these other factors are just a few examples of things that can cause interference in the moment. Things like being fatigued and exhausted, right? Not feeling as sharp cognitively toward the end of the day, just as a function of fatigue. Experience of pain. And sometimes it's not just pain, it's if medication is used for pain that can dull cognition and make memory and thinking more difficult. When we sleep is a restorative event for the brain, and sleep is a difficult thing in Parkinson's for many folks. And when sleep deprived, right, it shows up in high level functions like memory and thinking. right? Depression and anxiety as well, right? Absolutely. If those things are clinically significant, it can have a negative effect on memory and thinking. So I think it's important to understand it's a pretty complex process. Not everybody who appears to have a memory and thinking problem really does. Sometimes what you're capturing is interference from some of these other factors that are, and this is just sort of a short list here that's on this slide, but just something to keep in mind. We don't want to always assume that what appears to be a memory problem is actually a primary memory problem. It could well be a reflection of some of these complicating, distracting factors. So going back to that original question, right? So the person said, my family says I need to do a better job of coping with this. And in her mind, that meant sort of Parkinson's in general. Well, if what the family was referring to, right, there's a need to be more specific. If what was being referred to is a difficulty with memory or recall, then yeah, we know there's some very helpful strategies for those who have memory difficulty due to Parkinson's. And for many of these strategies can work for other conditions as well that affect memory. So one thing, for the first thing to really keep in mind is slowness in thinking overall means that it's going to be much more challenging to learn something new, especially if you only see it or hear it one time, right? So that's where we've got that slowness in thinking combined with that classic pattern of memory change in Parkinson's. Knowing that ahead of time is a little bit freeing, right? Because you're going to be more able to hear and ask for repetition, right? And know that just hearing it once doesn't mean you're not paying attention. It doesn't mean your loved one's not showing interest in what you have to say. It's just that whole processing and integration, encoding of information is a much, much slower process. It's also another very, very helpful to relate the thing that you need to learn or recall to your routine. If getting out of the house is a problem with all the stuff that you need, right, then it makes sense that we would use a strategy around that, like having a single solitary place where the bag that you take with you when you go to the doctor, when you leave the house is right there. So we want the environment to work for you rather than against you, right? Another really good example is timing of medicine, right? So if you take medicine twice a day, that's the easiest, because usually folks will combine it with something that they always do in the morning and something they do in the evening. Well, if you take medicine 3 times a day, well, if you eat 3 times a day, then maybe you tie it to that, and it's around that time before, a little bit before mealtime, right? And as the number of medication dosings increase, it can become more difficult to tie it to a specific routine, but that's where timers and alarms become helpful. But the general strategy is try to connect the thing to something that's already part of your routine or something that's really familiar. I can't reinforce how important repetition is. There are some folks that are really shy and feel bad when information is repeated, right? Almost like it's a slight, or it's an assumption that someone wasn't listening or someone wasn't paying attention. And this is where I think it's, for those of you that I've worked with clinically and those of you that I've met and talked with in multiple meetings, it can be, I'm a pretty direct person, and I think it can be helpful to just put it on the table that if it really is a weakness and a vulnerability, we want to advocate for ourselves, and you want to advocate for the people that you know and love, and use the strategy as part of an agreement, right? And that's where repetition and the willingness to ask for it if you're not sure, right? But also the other side of that is the willingness to provide it, knowing that it's the strategy, it's the tool to cope. It's not this annoyance, right? I've already said this 3 times, right? Why are you asking me about this again, right? Because everybody's human, right? There are going to be times when there's lots going on, and being in a care partner role has its own challenges. And of course, everybody is human, and there are going to be times that we do things better than others. But it's easier to repeat information from, a spirit of cooperation when you are able to recognize, hey, that's the strategy that we've agreed we're going to use. So it's easier to hear something repeated multiple times, but it's also easier to provide it as a care partner without it being tied to frustration and irritation, if you know that's the strategy.
Johnna, can I jump
yeah.
in for a minute?
Absolutely.
I just want to add that sometimes that happens in the clinic too, right? Because we're giving you instructions and then you're looking at me like, oh my God, I'm not going to remember this. And I'm like, okay, I'm writing it down as I'm telling you. So
Yeah.
the after visit summary is an important part of your visit because it usually contains all the instructions that we've discussed or the changes.
Mm-hmm. Yeah, absolutely. And I have, it is always my preference when I'm doing evaluations. There's the testing, there's the interview portion, there's the testing portion, but then there's the part that the data and all of that, right? That's at the heart of being a neuropsychologist. And that's really interesting for me. But the real fruit of going through that process that takes several hours is that feedback family meeting. Right. And that's where we take the data from the evaluation and you translate it to recommendations and strategies to help solve problems in day to day. And so it's really common that there's a family member that's taking notes. And we, as you say, with the after visit summary, we always say, hey, the report will be generated where you can absolutely get a copy of that. And that's one of the strategies. We want repetition. But sometimes what we also want is repetition in multiple modalities. So you're listening, you're going to maybe read it later on your after visit summary, someone's taking notes, and then it creates something that can be referenced later. So that's a great example. Thank you, Maureen, for what happens when you're in a doctor's visit or clinic appointment. The other thing too is you can use those same strategies in day-to-day life, and there are a lot of tools that you can use. We talk about, taking notes. You want to make sure when you're taking notes, so that there's one main place that you take notes versus 52 Post-its in all sorts of different places, right? And we'll come back to one of the points here, but this is just sort of an example. We've all seen these little dry erase boards here in the bottom left of your screen. We use this in my house, and it lives on the refrigerator. And we write for each day, this is the thing that has to happen at this time and what person it involves. And what's really helpful about that is it's a constant source of that reminder where you're not constantly thinking, wait a minute, was that Zoom call at 10:30, or I was going to log in at 10 because it starts at 11. Wait a minute, right? So that whole sense of making every aspect of your life a memory test, really, really stressful. So having multiple modalities, you're going to listen and pay attention and write things down, but you also it's helpful to have stuff posted in a visible space where very quickly there can be a glance. And this is the same kind of strategy that we use for folks that have much more significant cognitive change, where it's really hard to stick with information, but folks start to feel sometimes self-conscious of asking the same question again and again. We always recommend have it in written form. Always keep whatever you're using, whether it's a dry erase board or a daily schedule or a plan for the day, posted on the refrigerator. It should be where it's readily visible. And it creates sort of a tool for the person with the memory problem to know that they can always look there and double check and remind themselves. And sometimes some of those repeated questions can be reduced. And you also learn, hey, I can answer this myself. I just need to check that dry erase board. And maybe it's the role in that situation of the care partner to make sure that what's on that dry erase board for the day is accurate, right? So it's a team approach, but you always want to use as many strategies as possible that some of those questions can be answered by the person with the memory problem themselves. There are times, though, that there's no amount of time and using tools becomes really difficult, or it's just not feasible, where it's really clear that someone's really struggling to recall something. And if it's important, remember I said before, we want to use that tool of recognition when it's beneficial. In the moment, if retrieval is, the person is still struggling with retrieval, you can always present options to see if just hearing the word or the phrase is enough to trigger the recall, and your loved one can remember that piece. And I see this in clinic. So folks will say, "Ooh, Maureen started me on some medicine and it starts with a P and I'm not quite sure," right? And yeah, I can look in the chart, but I also want to know, if I say a couple names of things, what's going to be, what's that thing that's going to trigger the memory or the recall of it? And that's recognition memory. So when you're stuck, you can always default to presenting things in a yes/no format. We see this in restaurants, right? As folks start going back out and eating in restaurants, especially if you've been at home, like most of us, more in the last couple of years. You know, some of these restaurants, it's like the menu is a book, right? How in the world are you going to go back and flip through this whole thing and decide what you want? In that moment of too many choices and too many options, it's very, very appropriate for a loved one to kind of lean over and say, "Hey, are you thinking more steak or chicken?" Right? It just simplifies it and makes it a simple yes, no in the moment. Because the most important thing at that point is not that you thoroughly read the menu. It's that you're out there, that you're out together and you're enjoying your time together, right? So we kind of use these strategies when it's most appropriate, knowing you have a lot of different options for what you're going to use and how you're going to work with it in the moment. When we talk about using one main calendar or a whiteboard with a daily plan, those are good strategies. I love the little bowl with the key. In my house, it's this crock on top of the refrigerator. And so everybody knows, because that's the way that we come in. So I come in through the garage and then the kitchen is there. And so everything just gets dumped in that crock. And invariably, if I'm like, "Oh, where are my glasses? Where's my key? Where's my footwear?" I don't have to remember where it is or do this search, right? You just go to the place that it's supposed to be. But it has to be convenient, and it takes some time to set up that routine. But again, we want the environment to work for us rather than against us. So that's one example of, hey, coping means we have to understand what's the problem, what's the issue we're trying to work with in the moment. This is another common one that I hear is, "My husband speaks so softly that I can't understand what he says half the time. ... right? And then the ... can sometimes include, so I just give up, right? So now I'm yelling from the other room and now he says, why are you yelling? Right? A lot of you guys can fill in the blank with like all these different ways that this happens, because this is a common problem. So again, from a very straightforward, pragmatic sense, what's the strategy that we're going to use to deal with hypophonia, right? Which is that soft voice, and communicate as effectively as possible. The first thing is, I got those pictures of those old phones. The phone, it can be really hard, right? The phone, talking on the phone when someone's voice is really, really soft and speech clarity is diminished, that can be really difficult. And so a lot of folks don't like to talk on the phone, or they keep calls really, really short. If you have the luxury of being in the same location as the person, you should talk from the same room. So that thing of trying to shout from the kitchen to the family room and I can't hear you and what did you say, right? Just be really proactive and discuss things and talk from the same room, ideally when there's not a lot of external noise, right? So if the TV's on really loud, that makes it even more difficult to communicate and hear. Ideally, face-to-face, right? The other thing too that can happen is when speech is soft, sometimes we'll see that even if volume is good initially, the faster the person with Parkinson's speaks, sometimes the clarity of what they're saying diminishes, where there sort of can be words jumbled together or sounds that get mumbled together, and it's really difficult to kind of tease it apart. So that's one of those strategies where we say, hey, you got to slow down a little bit to improve that clarity. Use shorter sentences. The other thing that happens is if I take a big deep breath and I start talking, a lot of times volume starts out pretty good at the beginning of the sentence, but the longer the sentence goes on and the longer the person talks without taking a breath, the volume just kind of goes down to it turns into this little soft whispery thing that's hard to say, right? And it's really hard because you don't know what that last piece of the conversation was or the sentence was. So that's why we say, hey, use shorter sentences. Start by taking a breath and use your outside voice, right? So it's the opposite of what we learned when we were kiddos. You know, it's not the inside voice is sometimes not strong enough or loud enough. So shorter sentences, slow down if needed, take a breath. What I hope that the care partners that are on the call today can appreciate is sometimes the act of doing what I've already laid out here is 4 or 5 strategies, right, to help communication. That's very effortful. It's effortful and it can be fatiguing and just simply exhausting. And so we always wanted to keep that in mind, is that sometimes with Parkinson's, sometimes the changes in Parkinson's mean the thing that you used to do automatically without even thinking about it, you can work around it and have a strategy, but it means you have to direct and focus your attention on something, and you put effort into something that used to happen just automatically, right? And that process in and of itself can be pretty fatiguing. If you're not sure what was said, the strategy that I use, and I use this when I'm doing psychotherapy, I use this in evaluation, is I set the groundwork and set the stage, and I just very clearly say, hey, if I'm not sure what you said, I'm just going to repeat it back to you, and then you let me know if I've got it or not, right? So sometimes it's not that you didn't hear or understand the exact word, but you're not really sure what the meaning was, right? And that's, again, that's that collaboration where you're double checking. Hey, I heard this. So what you're saying is, right? And then you leave that opening for folks to correct you if you didn't hear it right or if you didn't get their meaning, right? And that's part of that partnership. And this is just another example of if coping with Parkinson's means doing something different, these are some strategies that we can use to help with communication. One of the other common things, and we're certainly going to leave time here for questions, but one of the other things that I hear a lot is we haven't even gotten out of the house and I'm already frustrated and exhausted. In talking with Julia before the start of the presentation, we were just kind of chatting about some of the challenges, but some of the other things that have happened that have been a little bit more positive, that we didn't even anticipate because of COVID. And this is one of the examples of folks being able to access a group or a meeting online, right? When for many folks, if they would have to get up and drive to Cincinnati or, right, make some trip to get out of the house to go to a meeting, there are a lot of folks that would mean on a particular day, even if they wanted to or planned to, they wouldn't be able to do it. So one of sort of the silver linings that if there is that in this time where we've still dealing with COVID, is that we realize there's a lot of different ways to do things, right? But what is a common complaint is this whole process of getting up and getting out and getting ready and can be frustrating, very, very difficult and exhausting, right? So what's the strategy? How do we work through that? I think the first thing we really want to appreciate is that we all kind of optimistically know the fastest and the shortest amount of time it's ever taken to get ready and get out of the house. And we want to be realistic, because the shortest time that it's ever taken for you to do it really isn't the average, and that shouldn't be the amount of time that you allow, because that would represent best case scenario. And we need to build in a window or a safety net, knowing that slowed processing speed, right? Bradykinesia, plus that slowed movement and slowed thinking, all of that means it just simply takes longer to do things, and it's more easy to get sidetracked. So in the spirit of advocating for yourself, you just always want to be kind to yourself and allow more time than you think you'll need, right? Because it's better to have 10 extra minutes than be worried because now you're 10 to 15 minutes late for an appointment, for a meeting, whatever it is. It's just in that moment that creates just a bundle of stress, right? That we hopefully can avoid if possible. I think the other strategy with that in mind is we want to decrease the demand to think and sort of work on the spot. So the morning of, that's the time where you want to be carrying out your strategy and your plan. So if you already know sort of what you're going to have for breakfast, and do we have that even in the house, and is part of that ready? What are we going to wear the next morning? Because if the morning is a difficult time, right, as we're waiting for first doses of medication to kick in and transitioning to the on state, then we want as much of that detail and prep work to be sorted out ahead of time. A lot of folks have sort of the to-go bag, which is the bag of items and stuff that they know they always need. And when they get home, you refill as needed for the next time you're leaving the house. It does take sort of a little bit of advanced planning, but if this becomes part of the routine, then it can give you a bit of a buffer to deal with emergencies or things that pop up at the last minute. They're out of your control, that can make it challenging to get out of the house on time, and to get and go where you want to go with it being as stress-free as possible. I think the other thing that's hard is, you know, I've been so fortunate to work with so many just bright, high functioning folks that they are so used to doing multiple things at the same time effortlessly. And it can be a huge adjustment to switch that strategy and that approach to really fully focusing on one thing at a time, right? That's a big switch, but the changes in the brain because of Parkinson's really demand that if we're going to be effective and minimize interference to the extent possible from anxiety and frustration. I'll just give one more short question that popped up, which I think is loaded with so many different things to set us up for one strategy I'd like to leave you guys with, and certainly how you work with it will vary depending on your life situation and the kind of things that you're doing. But this question came up where the person shared that our grandson is getting married in October and it's a destination wedding 4 hours away. We don't know if we should try to go or not, just don't want to disappoint him, right? And so big events like this, these are things that very often, even things that are happy and joyful things can be sources of stress and uncertainty. Because if Parkinson's contributes anything, sometimes it's that variability in day-to-day functioning and uncertainty of how things are going to be. Now, in this situation, the first thing was, oh my goodness, destination wedding. We need more detail to really start problem solving and coming up with a strategy so you guys can make a good decision, right? Because some destination weddings might be at a hotel where there's, you know, a room and then everything's going to be close by in a restaurant, and there's availability of, you know, it's easy to use a walker or a cane if needed. And I've worked with folks that the destination wedding was going to happen on top of a mountain, which meant that folks were going to have to climb X amount of steps, or beach weddings, right? So depending on how someone's doing and what their motor status is, you need to know more detail about what that destination wedding really entails. For this couple in particular, there was a lot of concern that how in the world were they going to be in the car for 4 hours and then feel able to have the energy and to be able to sustain good on time to actually participate in the events, right? And so we talked and worked through several different questions that they had, but at the root of it, there's a question that applies to many situations, and that is, what really is the trade-off, and what is the thing that's most important, right? Because in choosing the thing that's most important, what you have by default said is that other things are not the most important. And that's a good thing, right? The ability to clarify the thing that is most important to you also means that what you've acknowledged is that other issues are not what's most important. And so there's that trade-off, right? For them, they wanted to be at the wedding. That was the thing that was most important. But through discussing this in some detail, there'd been several other times where going on even short trips meant that there was a bit of a cost with some confusion, extra fatigue, lack of sort of more the usual response to medicine, some variability in motor functioning in the days that followed. It just kind of took a toll, right? And so that was part of that concern. But what this couple realized is, wait a minute, the most important thing is that we're there. So we're going to know that we need to have our own room where we can have some downtime to rest and then decide, hey, is this event, this ended up being like a thing where there were multiple things happening on multiple days. We're going to be there because that's what's most important, but we're going to have our own room where we can recharge when needed. We're going to have a look at the agenda and realize not every single event that's happening do we have to be at every event for the entire time, right? And so this whole notion of being able to pick and decide what is the thing that is most important to you, and accepting that that means there's a trade-off, that maybe you do it, but you do it in a different way, right? This meeting years ago, we would have all been in person. Well, we know now what's most important is that we meet, right? And that there's a time to share, and whether that's in person or online, right? It's just another example of identifying that and then knowing that there is a trade-off, and that trade-off is okay because you've made a good informed decision. Hope that makes sense. As always, I like to end with just a notion of, hey, this is a work in progress, right? So we want to do what we can to have a spirit of gratitude, remain engaged, prioritize daily goals, and celebrate that learning process through making mistakes for sure. Questions that you guys have, and I'll sort of team up here with Maureen in responding.
Johnna, this
Yes.
is Carol Ebner. One question, which is kind of like, sort of related, is if someone would really like to take advantage of your what you do, in other words, in developing strategies and assessing problems, what's involved in doing that? Do you have to get referrals? You'll have to go through the insurance companies?
Yeah, no, it's a great question. It's a great question. The first step is, I'm at UC, so I don't, it's always easier when folks have their neurologic care at UC, but it doesn't mean that has to be. Mm-hmm. Usually the first step is a referral from the neurologist, where you say, hey, I want to meet with Dr. Devoto to have a neuropsychological evaluation. And that's usually what I start with. Right. So the main role that I play is as a neuropsychologist is in conducting evaluations. 90% of the folks that I see have movement disorders, Parkinson's in particular. And so developing strategies and what's appropriate to do is oftentimes dependent on the level of someone's cognitive ability at the time. Right. So we want to make sure strategies match where that person is cognitively, also with a good understanding of what their support and their mood is. So Maureen makes referrals all the time, Dr. Duker, Dr. Espay, Dr. Hill, movement disorder experts in River Hills. Just you can request a neuropsychological evaluation, and then that message is sent to me. And in the process of scheduling, requests for pre-authorization for insurance and stuff happens after an appointment has been made. You don't have to do that yourself ahead of time.
Okay, thank you.
We have a few questions in the chat.
Sure.
And thank you, Carol, for that question. Someone in the chat messaged me privately saying I was going to ask that. So you read minds, Carol. The first question in the chat is, do the same strategies apply to dementia with Lewy bodies?
Yeah, they really do. You know, some of those basic strategies are universal. The thing that becomes more challenging is if you're working with someone who has, say, a moderate or advanced Alzheimer's disease, when those cues and hints don't apply, right? But when we're talking about cognitive decline due to Parkinson's or Lewy body dementia, or some of the atypical Parkinsonisms, or even lower body predominant Parkinsonism, like an NPH, those same strategies work, right? It depends on the features. You know, there are some folks, if there's a little bit of cognitive decline, but there's a ton of irritability and frustration, right? Or mood disturbance, or if you're trying to talk with someone who's actively hallucinating and you're not sure whether or not they've got insight to that, right? There's lots of, you would moderate and you would adapt how you respond. Again, that's why I talk about that trade-off, right? In the moment is the most important thing, that you help calm and maintain safety? Or is it that the way they described the thing that happened Sunday on Mother's Day was the way you thought it happened, right? You know what I mean? So it's always kind of about picking and choosing. We always say choosing battles, but I like more when we think about it in terms of what's the trade-off here, right?
Yeah.
That's a great question.
Oh. Next question in the chat. What is the best medicine for anxiety? I doubt if you can answer, but thought I would ask.
Well, you know, this is that sort of common thing that comes up. There are many different medications that can be used successfully and safely to treat anxiety and Parkinson's disease. This is where, because I am a neuropsychologist, I'm not a neurologist, and I don't prescribe, this is where I always kick it over to Maureen to give specifics, right? Because we want to make sure it's clear I'm not giving specific advice outside of what I do. The first strategy always is to make sure you're following your recommended dosing for your dopaminergic medicine, right? So when you're on Cinemet, whatever your dosing is, we always want to make sure that you maintain consistency in dosing, because that's the first strategy. Vulnerable periods for developing depression and anxiety, there's really three main critical periods for mood disturbance. One is as changes in the brain first start to happen and diagnosis is made. There are many people that in the weeks or months before diagnosis, they experience their first ever anxiety or depression. And in that situation, the first strategy is to consult with your neurologist to get on the right dopaminergic medicine. But there are multiple classes, SSRIs, but I'm going to decline to mention very specific medicines because we want to make sure that that is something that you work through with your neurologist, who has full awareness of everything that you're on for Parkinson's, and also to make sure that first your dopaminergic medicine, your Cinemet or whatever else you're on, is optimized. That's the first strategy in treating anxiety medically.
Does anyone else have any other questions?
Well, this is Anne. I first want to say thank you so much for this webinar, because I have been feeling so much more tired, and not myself, I am the caregiver, and thinking, what is wrong with me? And why can't I do what I used to be able to do? And probably it's because I'm the caregiver of someone who is declining in cognition and all of those things that are exhausting. And even though we might be doing the strategies, it is exhausting, and maybe that's why I feel the way I do. So I need to take better care of myself. I'm learning that.
Absolutely.
But I also have a husband who doesn't want me to go to his doctor appointments, doesn't think it's necessary. And I got any tips on how I can really convince him how important that is, especially he's had it 22 years. It's time for me to start going to those appointments.
Well, I think that I always start from the perspective, and, you know, of course, this is the neuropsychologist in me. Hard to get away from it sometimes, but I always start from the perspective of wanting to understand why he doesn't find it necessary, right? Because some folks will say, I don't think it's necessary because they want to guard or protect their caregiver from hearing how things are really going.
Okay.
Some people sort of get in that protective mode. Some folks want it not to be the thing that dictates what's talked about at home, right? And it's sort of a reflection of where they're at with adjusting to changes that are happening. Some folks want to not have it mentioned that they're skipping doses, right? So there's tons of reasons why folks want to go and not have a caregiver join. So that would be my the first step would be to kind of just touch base and certainly the time for that discussion is not the morning of the appointment. The timing is important. The time for that discussion is another day when someone's fully in the on state and they're feeling good and there's not a specific tension about anything in particular, where you're just kind of talking about how you're doing and how you feel like for you it would be really helpful. Not that you want to, you know, what some people fear is that the spouse is going to, or the caregiver is going to come in and start telling on them to the doctor, right? That's the part that I hear so much. And so, you know, just as an example, when I'm doing neuropsychological evaluations, we want family members and care partners to be there for the initial interview. And then the testing is done privately, you know, so we have them step out, the testing is done privately. And then as long as the patient agrees, we go over the feedback together. And I always say, hey, other people can see things in you that you may not see in the same way. They may describe it differently. They may have different examples. This is not to put you in the hot seat. This is just so that I have the most complete understanding of what's going on, because that's going to affect what we do, what recommendations we make, how we know what your resources are. And so I always sort of try to make a joke of it and say, hey, so we're going to give your wife a free pass to disagree with you today. And, you know, is that okay? Is that okay? And then we kind of laugh about it a little bit. And I always start with the patient and then I shift gears and say, you know, do you agree with that? Would you have rated that depression a 5 or a 6? Or do you feel like it would be more than that or less, right? So we want it in the spirit of coordination and just sharing information. But a lot of folks are afraid that they're going to be, quote, told on, right? So I would think just talk about it openly beforehand.
I'm sure that he has seen you because he has been through the Boston Scientific research. And I know he saw a neuropsychologist. He goes to Dr. Duker, so I'm sure he saw you, but never has he told me I should come in and be a part of the neuropsychology visit. He's always said, nope, that's just for me. So
yeah.
He's pretty good at working around the system.
Yeah. Yeah.
Thank you. Thank you
welcome.
for your presentation. I thought it was excellent. I didn't really want to come because I thought it was going to be a listing of what's going to go wrong, and it's going to decline, it's going to get worse. And I thought, I don't want to hear it. I know it intellectually, but the way you've approached the whole idea. Thank you. Nice presentation.
You're welcome. You're welcome.
I experienced going through the testing with you, Dr. Devoto, and the joy that I found at the end took away so much anxiety. Just to know that I'm on the right path and I'm doing all that I can to stay normal.
Yeah. Yeah.
So don't be afraid to do this. You know,
I
don't be
appreciate
afraid
that.
to
I
get
appreciate that.
evaluated.
Yeah.
Thank you.
Okay. Thank you everyone for your questions and statements. It is 12:01. We might, Dr. Johnna, could you take another question or do we need to wrap up?
We can take one more and then we'll wrap up for folks. I know a lot of folks do 12 o'clock meds, so we want to follow our plan. Yeah,
Awesome.
let's take one more and then we'll close for this session.
Okay, anyone have one last question? Please unmute yourself or type it in the chat. Otherwise, we'll just wrap up now.
This is just very brief, but when we were talking earlier about having an evaluation and then
Yeah.
the follow-up, is there a written out plan of suggestions that you come up with for dealing with some of these issues? Because, really, to be honest, it's hard to remember all this stuff.
It is.
And things.
And I can't speak for all neuropsychologists, but the way that we do it in my clinic is, we do that interview, we do the testing, and then on a different day, right? Because I have to go and score and interpret it. And then we pick another day when someone's fresh, right? Because it's hard to go through all of that testing and then say, okay, now let's talk about it. Because usually at that point, folks are sort of done. So we come back when folks are fresh. I present the data and we talk about it. But then what I generate is a report that sort of details those specific recommendations. And that absolutely is something that folks can get a copy of. There's just a little form that they sign for that to be sent. It's too much to do that day on an after visit summary, but very often other family members, if they come, they're writing notes as well. And then I always say, if you have questions later, because sometimes we know retrieval in the moment can be a hard thing. And it's, you're in the car driving home. And then, that question that you wanted to ask sort of pops in your mind. So that's why I always say, absolutely, you can get in touch afterwards to ask another question if it's just something that didn't come up. And the same is true for today's presentation. I believe, Julia, don't they have an ability to get in touch with you if there's other questions they'd like to ask?
Yes, absolutely.
Sure.
My email is jburks@parkinsoncincinnati.org. Or if you want to email the info email, and then I can forward it on to Dr. Johnna. So yeah, there's opportunities to continue the conversation past this presentation. Thank you so much for being here and taking time on your Saturday to be with us. And thank you to all of our listeners for taking time to be with us on a Saturday morning. We appreciate you guys and your continued support with Parkinson's Support and Wellness. I appreciate you all and have a great Saturday.